This is Bansari Patel. She's a nurse practitioner here at the University of Chicago who specializes, she's in the section of geriatrics and palliative medicine, and specializes in palliative care, hospice, end-of-life care discussions, works very closely with the hematology oncology group in the wards. Bansari, do you do any outpatient work also, or are you?
Oh, I'm predominantly inpatient. We do have an outpatient nurse practitioner that sees palliative consults.
Okay. So she did her undergraduate at Wayne State, and then her master's and her doctorate of nursing at UIC. And so I'll turn it over to her. Thank you.
Thanks. Hi, everybody. So you have, I didn't realize this until just a few minutes ago that the person who's going to be speaking next, Dr. Malik, had a lot of the same information as I did. So I don't want to bore you with the same stuff twice. So I'm going to go over just a few important things about hospice and palliative care, some of the services, and then the roles of a nurse or a nurse practitioner within palliative care and hospice. But then I wanted to switch and talk a little bit about advanced care planning. How do you do it? Why is it important? And then go over the Spikes protocol. I'm not sure if you guys have done that before or heard of it before, but it's a tool that we use to break bad news or talk about big decision-making topics with families and patients. So if anytime you guys have a question, I do not mind just you guys, speaking. I have no problems with that. So if you have any questions, feel free to ask. Okay. So we'll talk a little bit about the history and the growth of programs and services, but the main piece of this is really going to be about thinking about how is a nurse or nurse practitioner involved within a hospice or palliative care team, and then kind of what is their scope of practice, what are we able to do, things like that. So just can anyone tell me a little bit about what is hospice or what is palliative care, any personal experiences? Anybody?
Hospice is like maybe after the care you're getting there is not curative, but is meant to make you as comfortable as possible.
Yep. So hospice is designed for people who are at the end stages of their illness, or that we think that they likely have months to live. And the number that most insurance companies and Medicare put out is less than 6 months. And two physicians have to agree that they think that you have less than 6 months to live for you to be eligible for having hospice services. And they're really meant to provide care at home with a team-based approach. So that's why interdisciplinary teams are very important in palliative care as well as hospice. It's not just the physician, but there's the nurse who acts as the main case management manager, there's social workers, there's chaplains, there's volunteers. Some hospices that have more resources even have things like aromatherapy and massage, thinking about the total care of a patient at home, at the end stages. Also important to note that to be in hospice, you can't just sign people into hospice. You have to have an informed consent, either with the patient or their surrogate decision maker, meaning somebody who is able to legally make decisions, or there's nobody else in their family, and that kind of the decision making fall into this person. Any questions about that? Okay. And then palliative care, any experiences that you guys have had with palliative care? So palliative care is, I like to think of it as like an umbrella. All of it is palliative care, or palliative care is the same thing as hospice in terms of the intent is to provide comfort and relief of distressing symptoms and support a patient and family. But palliative care can be given at any point in the disease trajectory, not just at the end stages when you think somebody has months to live, but early on as they're diagnosed with a new cancer, as a way to provide symptom control while they're getting active treatment. Provide counseling as they're going through psychosocial issues, or link them up with appropriate resources in the community for additional help they might need. So it's care throughout the trajectory, not just at the end. Okay, so just really briefly, the hospice movement really started out in the UK with Dame Cicely Saunders. She's really impressive. She was a nurse, a social worker, and a physician. And she started her work with the terminally ill in the late 1940s and introduced this idea of specialized end-of-life care in the US in the early 1960s. You might be familiar, obviously, with Kubler-Ross and the 5 stages of grief. So she published on that in the late 1960s. And then in 1982, Medicare decided that it was time to create the Medicare hospice benefit, and then trying it out as a 4-year trial period to see if this would be a way to provide quality care for patients, but also be responsible fiscally. So in 1986, it became a permanent benefit, and hospices were given a 10% increase in the reimbursement rates. Do you guys know what is a daily hospice? I mean, I'm guessing you don't know, but like how much a hospice company gets paid daily to take care of a patient at home, like on an average? Like, so at home, they'll be getting like all of their care at home, meds, the nursing support, equipment that they need, the physician. So on average, the national average is about $150 a day. And in that $150 a day, you're trying to provide a whole team's worth full of services. It's quite difficult to do. And, you know, they do a remarkable job, like getting the patients, you know, the care that they need and the services that they need. I'd like to just mention really quickly the support study. In 1996, Robert Wood Johnson Foundation funded the support study. And this study has really impacted the culture of death and dying in the US, especially over the last few decades. It shed a lot of importance on why is it so important to communicate with patients and families about how are they doing with their disease burden? Is the cancer progressing? You know, what are realistic options based on where you are? It also shed light on the fact that we needed to educate not only the physicians, but other providers like nurses and chaplains and social workers on how do we provide quality end-of-life care and provide patients dignity at this time. I'm just gonna kind of scroll through this stuff, but if you ever are bored, Bill Moyers has an amazing series on death and dying in the US, and it came out in 2000. It's called On Our Own Terms. It is a wonderfully done series on what it looked like to die in the US in the 90s and the early 2000s. I'm going to quickly go through some of this stuff because Monica's going to talk about it too. Okay, it's just at the very bottom here in 2007, the National Quality Forum released a framework of how we should be providing palliative care and hospice services. So really, it was called the domains of care. And these are the areas that we need to include in the care that we provide patients and our documentation, especially for like, you know, CMS and Medicare and things like that. Do you guys remember in 2016 when there was all that stuff in the news about the death panels? Affordable Care Act? Anybody? No. Okay, so just briefly, the ACA is Affordable Care Act, Independent Payment Advisory Board. They were given the nickname the death panels at that time. And their main purpose was to think about how are we spending money on the sickest 5% of Americans. And these 5% of Americans are responsible for nearly half of the country's medical spending. So that's a big deal. But as you can imagine, telling people that you should just let your grandmother die rather than doing everything possible is not popular. And sometimes it's not a popular political decision. But I think it's important to note that 80% of the people that died in 2014, that was about 2.6 million, 80% of them were insured by Medicare. And I think that we don't oftentimes think about this as much, but these healthcare resources are finite. Medicare is estimated to only be able to pay 91% of its payments by 2026 and 78% by 2042. So I think we have to think about how we're providing care at the end of life, what treatments are going to provide benefit, and what are things that are we just doing just to do. And I think that this projected future of Medicare may mean less is paid to doctors, to providers, to hospitals. But I also think we need to be worried about what does it mean to the patients, because most of this care is going to be shit on to our seniors who are already living on a fixed income. So that's why palliative care, even geriatrics, is really designed to serve the sickest 5% that's driving 50% of the healthcare spending by having goals of care discussions, like figuring out what is most important to the patient. Also by addressing symptoms and see if we can keep people out of the hospital and discuss realistic expectations and treatment options with them. So obviously there's, you can see from this graph, there's been a growth in the number of Medicare certified hospices. I'm not spending a lot of time on this unless you guys have a question, because I think Monica's gonna go over in more detail. And we also have the unique Medicare hospice patients increased from 870 in 2005 to over 1.4 million in 2016. So we're seeing more patients in hospice, and the majority of them are oncology patients. And then there's obviously the other illnesses that we see in hospice often are dementia. We don't like to use failure to thrive as a diagnosis, but people who meet multi-comorbid conditions, heart failure, liver disease. Okay, so palliative care, like I mentioned, is the specialized care, specialized medical care with people with serious illness, and it focuses on really providing relief from symptoms and stress of a serious illness, and focusing in on the goals of a patient and their family. Not everyone's goals are the same, so it's really important to address what things are most important. And it's provided usually within a team, so physicians, nurses, social workers, and like I said, it's appropriate at any age and any stage of an illness. Okay. Other countries don't make this distinction as much as the US. I think it's because of our payer sources, but just know that they both have the same foundations, like in reducing symptoms and improving quality of life. But palliative care is anytime during the diagnosis to throughout their illness process, and hospice is only at the end. Okay, so this is the domains I was talking about with the National Quality Forum. When we see patients in the clinic or in the hospital or even at home, we're seeing them and thinking about these 8 domains. So I'd like to talk to you a little bit about what each of these means. So structure and process of care is really kind of, where are they? This is a, for example, 57-year-old woman with head and neck cancer receiving chemotherapy and radiation with a goal of blah, blah, blah. And then he or she might be coming in for a G-tube because they're having failure to thrive and not being able to eat. Physical aspects of care refer to all of your symptom burden. So pain management, nausea, constipation, any sort of symptoms, hiccups, like any sort of symptoms you can imagine, patients will get, based on like with the disease they're getting or the treatment options that they're using. Psychological aspects are really, are they anxious? Are they depressed? How are they coping? And I usually will ask patients, this is a lot going on right now, how do you deal with this? Or what helps you get through the day? As like just a way to kind of start the conversation. And then we use different screening tools to identify if they are anxious or if they're depressed, and if there's anything that we need to do in terms of medication management, or if it's something that we don't feel like we can manage, do we refer to psych or the chaplain? Just for like talk therapy or counseling. We do have in the inpatient side a psych onc. I think she's leaving soon, but like a psych onc psychologist who helps to do like cognitive behavioral therapy and talk therapy with our oncology patients. So that's usually I think really helpful. Many patients don't realize those services are available. Social aspects of care are, where do they live? Because you'd be surprised how so many of our patients sometimes are transient or may not have a stable place to be, are in and out of like random facilities or at friends' homes. So asking about where do you live, who brings you to appointments, who's in your family, who do you trust, is really important, because as they get sicker, you're going to need to know, what people did this patient value, whose opinion do they want to have included in this. So just to get that information while they're still able to talk to you and not in the middle of a crisis. Okay, so spiritual aspects of care. Not everyone's religious, and I personally, I'm not the greatest at this because I'm not a religious person, but I think that we need to at least ask if it is something that brings strength or comfort to the patient. And the way I do that is, with all that's going on, do you find comfort in prayer? Or where do you find comfort? Like, when you're not sure what to do. And ask it that way. I don't ask, oh, do you believe in God or things like that. That's just not my style to do it that way, but I'll ask in a roundabout way. And then, do you find it helpful to talk to somebody within, the pastor or the chaplain or somebody from the outside that you trust, including that in the care plan. Cultural aspects of care are things like, how does religion, I'm so sorry. How does language barriers or cultural practices make a difference in how they're going to perceive goals of care conversations, how they're going to accept treatment? I have a patient right now who is Haitian Creole, and like some of her practices and what her family is willing to talk about and not talk about are based on her religious and cultural background. And they don't want to talk about hospice, and they don't want to talk about dying and things like that, but at the same time, they don't want to do chemotherapy. So it's trying to navigate where they want to be with the information that we're giving and kind of what things are most important to them. And we see this a lot in, I think, a lot of cultures where they don't want to tell mom and dad because they feel like their parent will just give up if we say something to them. And sometimes it doesn't feel right. And I do always ask the patient themselves, if I'm able to ask them, how much do you want to know? Are you okay with your family making these decisions for you? And if they're fine with it, we have to respect that. Ethical legal aspects of care refers to advanced care planning, code status discussions. What would they want in the event, like, something catastrophic happened? So I think it's important to document who is the healthcare POA or who that patient trusts as like a legal surrogate. And then any other legal forms that we can fill out, like a POLST form. Are you guys familiar with what is a POLST form? Anybody?
I think it's the physician orders for life-saving treatment.
Yep. Have you ever filled out one? Or have you seen them filled out before?
I've seen them filled out. I think it's different by state.
Yes. So here in Illinois, nurse practitioners or physicians or PAs obviously can fill them out. And I don't have a copy. I thought I had a copy with me here, but you can find one on the Illinois Department of Public Health. And to be honest, anyone can fill it out, even if you're in your 20s. I think with all the stuff with the COVID pandemic, it was really interesting. We, within our own practice, so many of our physicians and fellows ended up filling out POLST forms during this time, just to make sure that their wishes were documented, so their families are not struggling if something, God forbid, were to happen. What would they want or not want in those situations? So you don't have to be old, and you don't have to have lots of medical illnesses or a terminal diagnosis to fill one of these out. Okay, and then care of the eminently dying refers to end-of-life care. So like when we're talking about hours, days, and in the hospital here, I don't know if you've seen the order set for it, but there's a comfort care order set, which is done so that teams don't have to wonder what should I start or where should I start, what is an okay dose. Every single symptom you can imagine, down to itching, is on there. And what are starting doses if they're naive or tolerant, and how would you titrate up? What parameters do you give the nurses on the floors? So it's all in the comfort care order set. If you ever have a patient that's in the hospital and actively dying, please refer to it. Okay, just a little bit of the historical background. The first palliative care program or consult service was developed in 1985 outside of out of Wayne State University. And then it became a board certified specialty in 2008. I mean, obviously the reasons why is because there were so many gaps that we were seeing out of the support study and this just healthcare in general. Families reported that 50% of the caregivers of Americans that were hospitalized, they felt that 1 out of 4 patients had inadequate treatment of pain and shortness of breath. One out of 3 reported inadequate emotional support. 1 out of 3 reported that they received no education on how to treat their pain and other symptoms following a hospital stay. And 1 in 3 were not provided arrangements for follow-up care after discharge. So that doesn't seem like, may not seem like a big deal, but it is. When people are not getting these needs met, it leads to more caregiver burden and stress at home. But these families these patients keep coming back to the hospital with the same sort of symptoms, and it's like we don't need to do this to them. Like there's got to be a way to address their symptoms and whatever their care needs are at the time. Okay, so I think this is really interesting. When I first started, and I've been doing this for about 14 years, palliative care was like, oh, it's just another word for hospice, because people got like, I'm gonna be honest, I think the word hospice scares everybody. So they're like, oh, let's change it felt like people just changed the name to palliative care or supportive care because it sounded less scary. And the definition has really changed over the last 14 years. It's becoming more evolved. We're not just taking care of people who have a terminal illness. We're taking care of people with multimorbid conditions. Like people we're not expecting to die in a year or 2 years. They might be around for longer. People with chronic liver disease. We're seeing people with chronic heart failure, pulmonary hypertension. Just thinking about people who have life-threatening illnesses, but also have lots of medical conditions that have a high symptom burden. Not just thinking about it as end of life. But the main attributes are that it is a medical specialty. You want to provide total patient care, meaning not just the medical piece of it, thinking about how does their home life, how does are they able to afford their medications? How are we going to get them their DME, their medical equipment? Are they able to get back and forth to appointments? Thinking about their care as a total patient. Making sure it's patient and family centered, trying to provide it within a team, because one person can't meet all of these needs. So understanding that we need to work within a team to provide it. And the main hallmark being effective communication and trying to be integrated into whatever other care that they're getting. Does anyone have any questions so far? Okay. All right. So obviously there's growth in the programs. I'm not going to go over this too much. There are some, I think there continues to be some barriers at the end of life. And these are the most well-documented ones. One, failure to acknowledge that there are limits to medicine. If this may lead, if we don't recognize this, inappropriate use of aggressive treatments that can only prolong the dying process and contribute to more physical and emotional suffering. There's also sometimes lack of training on primary palliative care, not expecting everybody to go and get a palliative care fellowship and, to be able to do this independently. But I think all providers, everybody, should have some primary palliative care skills, know how to talk to a patient about how to break bad news effectively, or think about basic things about pain principles, because before you consult to somebody else, just to see what you can do in the meantime. So basic primary care education, primary palliative care education. Sometimes people don't understand what services you get with hospice versus palliative care, and that might be a limitation. Also, rules and regulations with opioid prescription. People feel like they might be prosecuted for prescribing for some people, or what if the patient took too much and died because of it? Who's held responsible? And I think the other issue is that we sometimes don't know when it's appropriate to refer, because we don't know when the patient is nearing the end of life. Has anyone seen these illness trajectories before?
Yeah.
No? Okay. Ellen, is it? Oh.
Yeah.
Okay, so where have you seen these before and kind of what construct?
I'm mostly thinking of Atul Gawande's book, Being Mortal. I feel like he talks about different types of trajectories and like end of life care and how different people tend to kind of respond.
Mm-hmm. Thank you. So the top one up there, it's you see this like they're kind of like a high level of function. You could see like on the left side it says function, low and high, and then and along the bottom it says like a time, right? So cancer, you know, that people are doing okay for a while, and they might have some sort of event, but then it leads to a slow, continual decline to eventual death. And that time period can be, you know, where they're kind of stable and hanging out, can be shorter, it can be longer, but it tends to be like they're going along and then there's like a decline and they never quite get back up to where they were. The one next to it where it says long-term limitations with intermittent serious episodes, think of that with your heart failure patients or COPD patients. I don't know if you've seen anybody in the hospital with COPD or heart failure. They're going to come in because they're volume overloaded or they're short of breath or they're wheezing, and they feel better when they come back to the hospital. I think this is why it's such a challenge with some of these patients as they get sicker, because really home services are not going to keep them out of the hospital. It's your like IV diuretics and inotropes at times, and nebulizers that they are maybe not able to get at home. But if you see how it's like they're going along and then they fall, but they come back up, but they never get back to what their previous baseline was. And this continues for a while until they have a precipitous like event and then it's death. So I think those patients are harder to have, you know, you have 6 months to live, kind of, you should go to hospice conversation. But these are the patients that we should be really talking about. You know, if one of these times you didn't get better, what's important to you, okay? And the very bottom one, it says prolonged dwindling. That's our like failure to thrive, our dementia, our frail old ladies. They start out with a lower level of function and they just kind of hang out. And this prolonged dwindling can be going on for years. So a lot of times we might enroll somebody in a home hospice program with the dwindles, like with like the end stage dementia diagnosis. And they're like that for years. After a point, if they no longer meet criteria for hospice, they're not showing more and more decline, then they will be signed out of hospice. But just so you know, like, just to be aware when you're thinking about your patients and based on their diagnosis, that it's always important to talk about it in the event that this happened, what's important to you. And then and normalize it, but I talk about it with everybody. It's not just you, but we want to just know that we're doing what you want us to be doing with your healthcare. Okay, so I'm going to talk a little bit about what you get with hospice at home. And that national average, like I mentioned earlier, about $150 a day, they have to accomplish all of this that's on this screen. In Illinois, I believe we're at like close to 190, but that's only for the first 60 days. And after that first 60 days, they cut the rate down. So it like goes from 190 to like 150 or 160. So if you get somebody to live longer, they cut your rate. It's like actually quite interesting. So hospice, like I said, is a comprehensive care program. It provides care for end of life to patients who have months to live. Obviously, if we're wrong and the patient survives longer than 6 months, they can always get recertified. Or if the patient at any point decides that this is not what I want, even though they signed a consent, you can always sign out of hospice. It is not like it's like you're locked in. I think a lot of people are afraid that if I sign up for hospice, one, I'm never going to see my doctor. I'm just going to be sent out into this abyss and there's going to be nothing provided for me outside of comfort. But what I tell families is that even if you're enrolled in hospice, and let's say you choose your oncologist as your primary care doctor. I mean, obviously that's not what their role is, but you just like that comfort of coming back in, seeing them, even though they're not going to be providing any onc treatments for you. You can do that under hospice. It's just that you can't get cancer-directed therapy, but you can come in and for a visit as like a routine primary care visit if you're choosing that person as your primary doctor. But at home, you get interdisciplinary visits by the nurse, mostly the nurse and a nurse's aide. The physician comes out once when they're first admitted, and if there's any problems, and if the nurse feels like they need a physician visit, they'll come out. A social worker, which helps the patient and the family with counseling and grief services. Chaplains, if families choose for spiritual support. Not everyone chooses it. And then, like I mentioned, some hospices have ancillary staff, like people who do massage and aromatherapy. They do have some physical therapists, but at home, do not expect hospice patients to be getting rehab. That's not going to happen. Their physical therapy at home is limited to, let me teach somebody how to get their loved one to the edge of the bed, how to transfer from a bed to a chair. It is not meant for rehab. And like I mentioned, all of, or most of hospice care is done at home, and most of these deaths do occur at home, but there are other sites of care, like a nursing home, inpatient hospice, like within a hospital setting. We don't have one at University of Chicago though. Like Rush has a Journey Care unit, Mercy Hospital has Vitas, for example, which are both companies. So hospice covers your medical appliances and supplies. So what does that mean? It covers diapers, it covers your bedding, it covers wound care supplies, it covers suctioning equipment. If you need a nebulizer machine, it pays for all of that. Your catheter, if you need a Foley catheter for your urine collection, they provide for all of that. Any medications for symptoms and pain control, they will provide. They will not be paying for your Synthroid or your Lipitor or any other medications that are not directly related to providing you comfort. If the family is feeling overwhelmed, which you can imagine, taking care of a dying person at home can be emotionally draining, physically exhausting for some people. So hospices also have something called respite care, where loved ones can go into an inpatient setting where the nurses and doctors will take care of them there, but to give the family like a few days or a week of a break. Also, you can go to inpatient settings if your symptoms are too complex to manage at home. For example, we'll keep titrating up IV pain medicine at home with their PCA, and it's just not working. PCAs are patient-controlled analgesia to get, like IV pain medications at home. Or they're nauseated and we can't seem to manage it with the oral medications. They can always go to an inpatient, meaning in the hospital, hospice. Hospice also provides for the home health aide and the homemaker, who comes out about twice a week. Counseling and spiritual care, as I mentioned. I think the volunteers are very important in hospice in that they help to do things like legacy. I've had young women that we've sent home with hospice in their 40s who are dying and have young children, involving child life therapy, thinking about ways that volunteers can help them make videos or write letters is really, really important. And bereavement support. So when the patient dies, the hospice company, if the family wants it, will follow along for a year to provide counseling and support for that family. Okay, so again, all of the things I just mentioned need to be done in Illinois in under $190 a day. So that's why you can't get long-term IV antibiotics. You cannot have cancer-directed therapy, which costs thousands, tens of thousands, if not more. You cannot have radiation, and you cannot have blood products. Does everyone understand why that would be then? Like, is that clear? Or
I have a question about the $190 a day.
Yeah.
Is that like Medicaid in general?
Yep.
And that's making that limit?
So that is their Medicare, that is the Medicare hospice benefit. And that's what they have designated. And like I mentioned, each state is different. The national average is about 153. But yeah, so actually it's like exactly $190 that Medicare decides is what you're gonna get, and you have to fit all of this care into that. Obviously you get more if you, for example, if the patient needs to go to inpatient, then they have like $800 that you can spend per day to go to an inpatient setting. but all of the other insurance companies like Blue Cross, United, Aetna, they tend to follow Medicare's framework. Some, like for example, everyone thinks, oh, Blue Cross, it's a great insurance plan, but there's so many gradients within each insurance plan. There's some that only like the benefit is for like 1 month of hospice. So, yeah, so yes, most hospice companies follow Medicare's benefit, but obviously there are some there's some variances within the hospice companies as well. Okay, so the reason why I make such a big stink about like knowing what the hospice benefit is that patients have to understand when you're signing that consent, you're choosing hospice care instead of other like your type A, Medicare Part A, which is your hospital insurance. You're choosing hospice instead of that. So that's why you're saying, I'm not coming back to the hospital. If you decide to come back to the hospital, you really need to let the hospice company know that you're choosing to sign out of hospice because you will end up being held responsible for that emergency room bill if you don't let the hospice company know first. Obviously, like if that happens, the hospice company tries their best to make sure that the patient is not billed for that, and they change documentation if they need to and things like that. But just knowing that if you want to come in, you can come in, but you have to let the hospice company know you're choosing to sign out. And then the other piece of this is that, like, for example, we'll say somebody with breast cancer. Let's say they trip over a rug and they fall and they break their hip. Of course, they could come back to the hospital. But again, they just have to let the hospice company know that, hey, I think I fell, my hip is hurting. And if they need to get a procedure, like, to get their hip pinned or something, they're able to do that, even though they were initially in hospice. They just have to let the hospice company know. Okay. I think I talked about this. Medicare doesn't pay, or Medicare hospice benefit doesn't pay for room and board at nursing homes. So this is something that I see quite a bit. Families tell me, I can't do this at home. I can't take care of, my father. I can't take care of my husband. I can't take care of this person at home. I need them to go somewhere. This becomes a big issue if they don't have a secondary insurance. Medicare's hospice benefit will only cover your hospice, but it doesn't cover room and board. So you need to have either public aid or a secondary long-term care insurance. And many of our patients don't have the resources to have a secondary, secondary long-term care insurance. So oftentimes we'll work on thinking about, can we apply for public aid? Can we do inpatient for a while and teach the family how to provide this care at home? So just finding other solutions. Okay, the one thing I want to make clear on here is that for palliative care services, it is in no way a replacement for hospice. It's a visit at home once every maybe every 2 to 3 weeks by a nurse practitioner or a physician. Think of it as a consult. That is all that it doesn't cover social worker, it doesn't cover nursing, it doesn't cover medical equipment. All of that has to be done separately under their insurance. And it's paid for just like a regular consult service. So why are hospital-based palliative care teams so important? I think this, most people are first introduced to palliative care in the hospital, and we know that hospitals are where the sickest people are. More than 53% of people die in hospitals, and many of these people need palliative care to complement their life-prolonging therapies or to even transition to comfort. We know where this is where most of the money is spent. Nearly all Medicare patients spend at least some time in the hospital in the last year of their lives. So just being more responsible and thinking about how we're spending like that patient's time. If they have a limited amount of time, how do they want to spend it? And we also know that patients in the hospital are there because you need to plan for the next phase. They're here for a health crisis. And this crisis makes them confront, or sometimes leads to like confrontation with, where is this all going? What decisions need to be made about the future? And those are like the main hallmarks of palliative care, this communication and coordination piece. Okay, so these are the reasons I get consulted a lot. Teams and families need help with complex decision-making or goals of care. What does it mean? What do you think goals of care refers to? What do you think that means? Anybody sit in on a goals of care and like whenever, if they've been in the hospital?
It's kind of like setting expectations for whatever treatment or care that they're getting. So if it's not meant to be curative, making sure that that's known.
Yes. So are you familiar with the spikes protocol? Anybody? Okay. So the spikes protocol, I would say just if after we're done here, I recommend Googling it or looking it up somewhere else, however you get your information. The spikes protocol, I think, is really helpful as basically it's a roadmap of how you're going to break this bad news. Each letter stands for something, right? So SPIKES, spikes, like an actual spike. So setting meaning, setting, perception, invitation, knowledge, empathy, and summary or strategy. So setting, when you're having a family meeting, it's so important to do things like put your phone and your pager on vibrate. Make sure that everybody that needed to be there is able to be there. If people are not able to be there, trying to get them on the phone or whatever else. Making sure that you have time. Don't do this when you're in the middle of rounds and you want to try to get in and get out in 10 minutes. That's not helpful to you, and that's not helpful to the patient. So sit down. If you're able to sit down in the room, obviously sit down in the room. And I also always ask the patient, do you want this conversation to be had with you in the room, or would you prefer that we talk to your family outside? Just so that, that we found out what the patient's wishes would be. Perception, that's the P. And that's where we're understanding kind of what is the patient's understanding of their illness and the current clinical situation? What does the family know? I can't tell you how many times the patient that I've experienced this, that the patient hasn't told the family that, yes, I have cancer, but how bad it is. And families are coming in for these goals of care meetings or conversations, and we're telling them, well, now this is widely metastatic. For example, last week I had a woman, she was found down at the L. She was, along with having metastatic breast cancer, she also has a illicit drug abuse problem. She was found down after she must have injected something. The family knew she had cancer, but she never told them, the fact that it had spread back in December, where it had spread to. And she was transient, meaning she would just move from random people's houses, sometimes her family, sometimes some friends. So none of the family knew that her cancer was as bad as it was. And when we're telling them, you can imagine, a lot of this now we're also doing virtually, which makes it even more complicated. Families can't see their loved ones in the hospital, and we're doing everything on a screen. And telling them, like, oh, by the way, it's metastatic to the point where now she's not going to get treatment. Oh, also, like, this woman also had come in with a subdural bleed from the fall, but now had a brainstem bleed. So she's now on a completely different level of, what her prognosis is and what we can expect for her future. So, like, really getting a sense of what they understood, because they, like, in that family meeting, they had no idea. So starting at the beginning, your mom was diagnosed at this point. This is what treatment she had. This is what happened in December when she came in. This is what she chose to do at this time. And when she's coming in now, these are the new findings. So making sure you understand where they're coming from. But then I always say, how much do you want to know? Like, do you want to know all of this information? So inviting that information. So that's the I. And then I share with them the knowledge that we have. And I would stress the importance of not using big words. Speak in layperson's terms at all times, because I've been in meetings where people didn't know that prognosis, when you say cancer is progressing, they thought that meant that was a good thing, or metastatic, and not knowing what metastatic meant. So just don't assume everyone knows the same lingo. So I always say that means it has spread, and I explicit, this is where it spread to. This is what it means. Empathy, meaning this is a lot of information. I can understand that you're frustrated, you're scared, or like acknowledging that emotion that they're showing you, but in no way, I never say I understand how you're feeling, because I don't, obviously, but I just really, you just want them to know that you're here. Like, how can I help you through this? And then summary or strategy is the S in spikes. And then that's basically where I summarize. Okay, so this is what we talked about. With all of that's going on with your mom, These are the treatment options, or if there's no treatment options, that are being recommended. At this time, we recommend that her care be focused on comfort. But I understand this is a lot of information. If you want to get more information or talk to other people about this, we can refer you to a hospice company. And that's how I usually, I do that. I said, let's just get some more, especially when families are fighting against it. Like, I don't know if I want that hospice being she's dying. I'll often say, well, let's just get somebody in to give you some more information about what they can do for you at home. And then you decide if this is going to work for you and your family. We're not here to force people into anything. Any questions about that? Okay. Prolonged hospital stays, when people are here for more than 30 days, we sometimes get consulted for that. And if they have a poor prognosis, or somebody, like the teams don't know, are they really eligible for hospice or not? And then we've been active during this COVID role with all this COVID pandemic stuff. Many of our team members are providing primary care in the nursing home. We see patients in the emergency room for goals of care, for code status discussions, because we get all of these nursing home patients that come in through the ED. A lot of times, some of these advanced care planning discussions have not been had. So we're cold calling families on the phone. Oh, by the way, your loved one is here and this is what's going on. You know, what sorts of things were important to them? A lot of times, obviously, family hasn't seen that person in a while. They're always going to say full code or do everything you can do. But so our palliative care team does go into the emergency room. We also see patients in the nursing home that we work with closely, providing primary geriatrics and palliative care. And then on the COVID units as well, we see people for goals of care conversations. We are allowing families to come into the COVID unit to say their goodbyes when we've actually made that decision to focus on comfort. And we address symptoms and care planning in that unit as well. I think the COVID role, like the COVID unit and like all of that, I think we've really tried to meet patients and families like where they are, but it really shows you the disparities that we have. Just like most people don't have the ability to FaceTime or Zoom. And we're asking them, oh, do you want to talk over? I personally, I guess it's like, I didn't think about it as much, but it's incredibly challenging when family members are elderly themselves, or they're not able to use some of these virtual tools that we're using. Also, they don't feel comfortable making these decisions over a screen. Like, and I can completely understand that. Any questions about that? Okay. So one last thing I wanted to say about like the benefits, I'm actually going to talk about something negative. So a lot of studies show that, you know, palliative care is so great. It does so many good things for a patient, for a hospital, cost reduction. But it was interesting. There was a JAMA article from 2016 that found that among families with patients with chronic critical illness, the use of palliative care led supportive meetings compared to usual care. One, did not reduce anxiety or depression, but it also may have increased post-traumatic stress disorder symptoms. I imagine what's happening is that these patients are already at a heightened level of anxiety. They're scared about their future, the unknown, and the fact that somebody is is openly talking about all of these things may make it seem more real. But I see this all the time. Families don't want to hear negative information. I think ICUs make everything like seem more real. But I think that if you don't share this information, oftentimes I've also heard on the other side, why didn't somebody tell me that this could happen? That's why, again, advanced care planning, so important, and do it before we get to a point where they're in the ICU. All right, so team members. So we talked about that most teams include a physician, an APP. So APP is a word that you'll hear often. And APNs, which are advanced practice nurses, and PAs often get lumped together. We have a different training background, but we do a lot of the same things. So we're lumped together as APPs, advanced practice providers, registered nurses, social workers, chaplains, and volunteers. So teamwork is complex, but it's an essential component of palliative care. When people are diagnosed, like I said, with these complex illnesses, their needs are going to vary from the time of diagnosis, when they only want to talk to the doctor about what you can do, to as they're struggling financially, to as they're like having trouble talking to their kids. Like the different team members will need to be involved at various stages of their illness. Our team, our inpatient consult team, is essentially run by a physician and us, the APNs. We don't have other people directly on our team, but we utilize the floor staff of social workers and chaplains. So what is the registered nurse's role? Okay, so RNs are the team members. So they're the team members that are going to spend the most amount of time with the patient. In the hospital, this happens, but also at home. There are case managers, like in the home setting, they're the ones who let the physician know that, you know, these are the symptoms, this is what I think is happening, what would you like to do? In team meetings, they help to, like, they have weekly hospice meetings where the nurse will present the patient and what the care needs are. So these palliative care nurses have to be not only able to address the pathophys of, you know, chronic illness, but also advanced pain and symptom management, how to address, you know, certain symptoms at home. What are things that they can do without calling a physician, providing counseling to the family, and continuing the advanced care planning. They also need to know how to talk to people about what is the dying process. Oftentimes at home, it's the registered nurse who's going to talk a family through, these are the signs of dying. This is what physical things that you're going to see. This is what behaviors you might see. Okay. So registered nurses that work within hospice and palliative care can work in a variety of settings: home, hospital, nursing home. But prisons, there are quite a few prison, hospice, and palliative care programs, especially with these penitentiaries where people are going to be there forever, like if they're serving life sentences. The hospice nurses teach the inmates how to care for their fellow inmates. And these inmates are the ones who are providing the day-to-day care for the dying prisoners, like who are going to be end up, like if they're on, like, you know, life sentences, they're going to be dying there. So like they're the ones who wipe them up or help turn them, change briefs if they need to have diapers and stuff changed at the end. Okay, so like I said, APP just means Advanced Practice Providers. Do you guys, have you ever worked with nurse practitioners before on any services? Okay. So advanced practice nurses are basically nurses who have then gone on and gotten either a master's or a doctoral degree, and you get specialized. So there are like adult nurse practitioners, there's geriatric nurse practitioners, pediatric. Then we have clinical nurse specialists who are also considered APPs. They're really, their role is more on education for staff. Then we have nurse anesthetists who work in the ORs with the anesthesiologists, nurse midwives who are also APNs. So APNs or nurse practitioners can provide roles in either primary care or specialized care, like so infectious disease, oncology. You'll see a lot in the oncology clinic, as well as the inpatient oncology services. And the practice of an APN is regulated and like licensed and regulated by individual states. So some states allow for full prescriptive authority, meaning a nurse practitioner does not need to have a collaborative agreement with a physician. They can practice on their own without having any sort of supervision. Some people choose to do that. You don't have to do that. Illinois is a full prescriptive authority state. So APNs here can choose to work without a physician collaborative agreement. So PAs come out of the medical model. You don't oftentimes see a PA in palliative care. They're oftentimes, since they're following more of a medical model, you might see them more in the ORs or on clinical services. They diagnose and treat, they prescribe medications just like APNs do, but their training is more in the medical model, whereas nurse practitioners are taught in nursing theory, which is thinking about how is the environment impacting that patient, or like thinking about a holistic approach and looking at it and not so much as looking at it as like a disease and how it's impacting the patient's life and what you can do to address that. in my role, it's changed so much over the last 14 years as our services and what we were providing the hospital has changed. Starting out, I had more of a resident role where I see a patient, I'll come up with my own plan, I'll present it to an attending. After a certain point, you gain trust, and then you're seeing patients independently and calling once in a while if you need help. And it evolved into, we had 2 separate services, and I was running a service independently as we're able to bill, order narcotics for our patients, document, run goals of care. So, I think this role just evolves, and every state is slightly different. But in my role, I'm able to do quite a bit for these patients, especially in our oncology services, developing care plans, running family meetings, prescribing any symptom medications that they need. I think this is collaborative versus solo practice, just so you guys are aware. We know that there is a significant growth in the number of palliative care programs, and there's been growth in the number of providers, but there's a huge shortage in palliative care providers, especially physicians. The future, like by 2030, it's estimated that there is only 1 palliative care physician to 26,000 patients who would need palliative care. So there's not enough providers to go around in terms of medicine providers. There is a big push for nurse practitioners to be in this role as well, to meet some of this need. And some smaller hospitals or community settings or rural areas don't always have access to palliative care teams, and they may utilize a nurse practitioner to kind of fill this role because they're going to be able to do the nursing piece of it, but also, take a history and physical, determine like what are the issues here, where to refer to, or what to prescribe. But I personally think a collaborative agreement or a collaborative practice where there's a physician and other team members like the social worker and chaplain make this a much more fulfilling for the provider, but also you're getting the patient everything that they need, especially at the end of life. Okay, so I don't know if I have more time to go over, actually it's 4 o'clock, I'm sorry. Is there any questions you guys have? Hello? No?
Thanks. This is Alwyn. Thanks so much. That was great. But I do think it would be great if anybody has any questions. Particularly, I think about the piece about the nurse practitioner and the collaborative piece would be great, since I think the palliative care collaboration between physicians, our advanced practice providers, but just also really a multidisciplinary position, kind of area. And I think it's been an amazing addition for to be a great person to ask me to.
All right.
Hey, my name is.
I'm
sorry. My name is Maria. I'm a first-year medical student. I was really interested in what you said about people who are in prison and palliative care and what that looks like there. I was wondering if you could speak a little bit more about that and kind of like why is the model to have other inmates take care of their fellow inmates. I had no idea that's how that works.
So I think earlier on when I mentioned that Bill Moyer series, Dying on Our Own Terms, or like On Our Own Terms, that's where I first saw it. And it was in a prison in Louisiana where, in the Angola prison, where all these inmates are there, they're all serving, they've done horrible crimes, they're serving life sentences. They all know they're going to die there. And so they had a chaplain who brought in a nurse, and then they decided to create a end-of-life unit in this prison. And they found that, the nurses and medical staff are not able to come in that often, but there's things that these inmates can do for their peers. And they all recognize that they're gonna need each other. They're the ones who are burying each other. You know what I mean? Because in the prison cemetery. So they found that in that video, like they'll talk a little bit more about that if you end up watching it, but like they recognize they're going to die there and they wanted to do better, and like a way to also redeem themselves. Like they've done so many horrible things, but they now want to give back. So it started out with a chaplain coming in, and they recognized that there was like, oh, there's people here who are having distressing symptoms. Maybe we can bring in some other like hospice team members, and then it just kind of grew out of that. And then they basically taught the inmates basic things. They're not giving medications, but like things that you can do for comfort, like oral care, how to turn them, how to, you know, like if they're feeling short of breath with a fan, like things that you can do to provide comfort at the bedside. There's a hospice downstate in Carbondale that also has a pretty robust prison hospice program too. But I can send out the link to the video if you guys want. I can email it to Dan if you're interested.
Yeah, that would be interesting. Thank you.
Mm-hmm.